So as we did with looking at soft tissue with respect to old osteopathic writing, what we're going to do here is we're going to take a written description of a method that Dr. Still has in research and practice, or osteopathy research and practice, speaking about setting a hip. Now, one of the big challenges is that with written descriptions, if you want to make them accurate and reproducible, or very clearly reproducible, you need to use a lot of words. And even when you feel like you've used enough words, there may be things that you're missing just because you're so close to it and you take some stuff for granted. Now, the method that Dr. Still talks about for setting a hip, he says it's one of many. And what I'll do is I'll make sure that in the post on my website that I'll have the actual quote, and I should probably put that in the YouTube description. So it should be below this video if you scroll down and it says show more. So it should be there. What he talks about is lifting, holding at the foot, holding at the greater trochanter, or the trochanter major, as he says. He speaks about first, prior to that, you loosen the muscle of the articulation. Doesn't give a description of that, so we're not sure what that means. It could mean many things, but it's all supposition because we don't have the information. So that turns into a vacuum situation. There's no information, so we'll fill it with whatever we want to fill it with and say that we're correct. If there's no information, we can simply say there's no information and we can move on from that. But he does say loosen the muscles or soften muscles at the articulation, or the soft tissues at the articulation. And he says holding the foot and the trochanter major. So my general hold will look like this with most patients without a hand in my, or without a leg in my hands. Speaks about holding in and around the heel, lifting with a slight bend in the knee. Now, to maintain a slight bend in the knee without having it come away, it's very difficult when I start to move the leg around, right? I have a hard time controlling this. So what he does speak about is either with the chin or the chest. So it would look like this or look like this to maintain that. When he speaks about pushing over, so he talks about bringing the foot towards you and the knee away from you. So the method essentially looks like this in totality. So he talks about lifting with a slight bend in the knee. Now, he doesn't say make contact with the knee to keep it stable, but he does say to eventually use your chin or your chest to push it away. Speaks about having a hand at the trochanter major, so in this case it's the greater trochanter. It says bring the knee up to the patient's chest. Then what you do is you push away, right? So you start to push across. Now this becomes very easy if I have my chest on the patient. And then he talks about bringing the foot towards you at the same time, and then bringing the lame leg over the good leg. You bring it back and it's set without a pop. So some things that we want to talk about here. I have seen this method demonstrated by another individual in quite a practical fashion, where the knee was quite bent, and I do this quite often myself. So I've talked about this in many situations where I'll talk about kind of wrapping around, hooking around the foot and the ankle, so I've got lots of contact with my forearm and my hand. My fingers are coming back around the heel, contact with my thorax, with my chest, on the patient's leg, so leg below the knee or shin, depending on which terminology you prefer. Anatomically speaking, this is the leg. Hand under the trochanter, or in and around the trochanter, you can come up, come through, straighten the leg, and let it come down. Should you want to turn that into the chin, you can do this. I just think most people in this day and age would find this a little disconcerting in most cultures, in most countries, to have somebody's chin on your knee. One of the reasons why I have a bit of a problem with this is because as my hand's at the trochanter, as I come around and I straighten that leg, as the leg comes down and the knee straightens, if there's any challenge with that knee, any anatomical disruption with that knee, any problem with that knee, as it drops out into an unsupported position into full extension, you may be re-injuring the knee, injuring the knee, causing discomfort to the knee. So when I tend to do this, because of the concept of relational motion, I'll use my eyes, right? So as long as I don't have the pelvis rocking all over the place, the table stabilizing the pelvis, which means the acetabular side of the hip joint is fairly stable, relatively speaking, not perfectly, but I can come around and I can do the same thing. I can even let the leg away from my chest because I've got good contact with my hands, and I can work on the hip that way, right? It might look like this, so I might turn my hand this way so my thumb goes under the knee just for some support at the knee, right? Because my general preference is to make sure that that knee is supported. So the same method, right? The same idea of hip flexion, internal rotation, knee coming across the body, so adduction of the thigh, and then straightening the leg, so essentially knee extension. Those are the movements that Dr. Still's talking about in totality. The visual description that you get, or the thought description that you get for the individual method could be many things, but just again to reiterate what that could look like from an operator or a practitioner rather standpoint. So the practitioner standing, it could look like this, so you get that slight bend in the knee, which is hard to maintain sometimes, especially if a patient can relax. Hand under the trochanter, come up, internal rotation, so the knee goes away from me and across the lame, or across the good leg, the lame leg goes across the good leg, and the heel comes towards me, right? And then that's one way. Could look very similar, where again, the patient's knee is against me and their shin is against me. I use my chin essentially as another hand because I can approximate the space between my chin and my thorax. I just think a lot of people may be uncomfortable with this as far as patients are concerned. But same thing, hip flexion, internal rotation, and adduction, and then back. It could look like very similar. Here I can have my hand at the trochanter. The reason I don't like this very much is because the knee can go into extension too fast and harm the knee. So I will tend to do it this way. So I'll hold here, right? So I've got good contact here, contact. My thumb goes under the knee to protect it. And I use my eyes to make sure that the pelvis isn't going all over the place. Again, hip flexion, internal rotation, adduction, come down. So those are 3 or 4 possible ways the same description would look in action. Now the challenge with that is that each one of us will read that, and because there are words missing or kind of specific descriptions missing that could give us a greater understanding of exactly what he's talking about, which would take a lot more words, we will tend to fill that with a vacuum, or we will tend to fill that with our own biases and our own preferences. The vacuum that exists with a lack of words and a lack of description or a lack of accuracy, we will fill the vacuum with our biases and preferences. So I'm trying to show multiple ways that the same thing could look, but the key points with what Dr. Still's talking about as far as setting a hip is hip flexion, internal rotation of the thigh, and adduction of the thigh as well across the midline and then coming back out. And he also talks about body contact. So the concepts that we're getting here, where he's not saying this, but the parallel can be made, is that especially with the way that I show it and the way that I speak, we could be talking about relational motion. So the pelvis is stabilized by the table, and you're getting the hip flexion, the internal rotation of the thigh, and the adduction of the thigh. You're getting all of that against a stable table. So you're talking about relational motion there, and you're also talking about contact as control, or broad contact. So the contact as control portion is when he talks about using your chest, right? Using your chest or your chin to push the knee across the midline, and also the hand on either side. So he's sensing what's going through the full thigh. It's going up through the full leg with that hold, but you're getting the concept of contact is control in that description. So to take an old description or an early description and identify how that can relate to some of the concepts that I'm speaking about. Now, understanding that the problem of filling a vacuum with a bias might be occurring here. I may be filling a vacuum with my own bias. And what I'm really trying to do is provide systematic statements or systematic guidelines that will allow you to understand how anything works or how to apply anything in a fairly safe fashion for the patient. So the idea of relational motion, contact as control, or control as safety, those concepts can be applied to everything. So if I show it to you in more situations and possibly related to historical descriptions that you value, that you like, it may help you understand them better.